Good afternoon, everybody. Welcome to Grand Rounds. Today, I have the pleasure of introducing Dr. Maryrose Bauschka. Dr. Bauschka attended medical school at Case Western Reserve. She then completed her psychiatry residency at the University of Utah. She's currently medical director and attending psychiatrist at the Eating Recovery Center and Pathlight Mood and Anxiety Center, and also a clinical instructor at the University of Colorado and adjunct assistant clinical professor at the University of Utah. She very kindly has accepted our invitation to present today, and she is going to provide us with some pearls in regards to management of eating disorders. And please join me in welcoming Dr. Bauschka.
Thank you. Thank you so much for the introduction and for inviting me to present. I love to talk about eating disorders, so I'm really excited about this presentation. And I'm really going to focus on eating disorders from my perspective as a psychiatrist. There we go. I don't have any conflict of interest to report related to this presentation. And what we want to talk a little bit about is how malnutrition affects the brain. This becomes very important in looking at a variety of psychiatric symptoms that we can see in individuals with eating disorders. And I'm just going to apologize. I'm in downtown Chicago, so you may hear sirens and traffic outside. Other things we'll talk about are potential vulnerabilities, as well as the initiating factors and maintaining factors for eating disorders. What kind of psychiatric medication options do we have, or other management strategies? And look a little bit about how weight stigma and weight bias can affect a patient and their care. So eating disorders are highly prevalent, both in teenagers and in adults. And so regardless of the area of medicine or healthcare that we're working in, we are seeing these folks every day in our practices. And what's important to know is that most of the time eating disorders do start in childhood and adolescence, but they aren't just diseases in that time period. And we see folks, I've treated folks well into their 60s and 70s with eating disorders. Males are 10% of the eating disorder population, although we are starting to question that estimate. We actually think it's higher. Other important populations to think about as you meet your patients with potential eating disorders is folks who have a transgender identity, low-income families. So what we know is food insecurity, particularly in childhood, is a risk factor for eating disorders, as well as teenagers, Black teenagers, but individuals of color often are folks that we miss diagnoses in and often are have decreased access to treatment. So COVID made everything worse. I think that's pretty easy to say in most areas of healthcare, but we did see a worsening of eating disorders and a pretty rapid onset of new eating disorders, particularly in adolescents who were staying home from school. This really peaked within that first year, and we still continue to see higher volumes of patients than we had been previously, and folks are much, much sicker. This also has had an impact in the delivery of care. So now you'll see a lot more virtual options for eating disorders. As you know, the state of emergency ended in states, a lot of times that decreased our ability to do that virtual care, but there are more and more programs now who have arisen in this time period to serve needs virtually. So if you work in a primary care setting, how do you screen for eating disorders? So there are several screening tools. The USPSTF has concluded there's insufficient evidence to assess benefits versus harms in adolescents and adults. I would disagree with that. We do know that early intervention is crucial, and most patients with eating disorders are not going to show up to us in our clinic or in our office and say, I have an eating disorder. They're more likely to show up with a variety of GI complaints or other physical complaints, or they'll come to you with concerns about depression or anxiety if you work in the mental health area. But some options for screening tools include the SCOFF and the SBIRT for eating disorders that can be very useful tools for screening the patients, but also opening up the conversation with them about their relationship with food and weight and their body. So eating disorders are complex neurobiological illnesses. They have those biological vulnerabilities, temperamental vulnerabilities, and social and environmental risk factors. And when we do treatment for eating disorders, we really need to focus on all of these areas in order to best move patients towards their recovery. And so what I like to talk with patients about and think about myself is, what are the initiating factors for an eating disorder? We'll also think about maintaining factors. So often an initiating factor for an eating disorder is a vulnerable individual. And we know folks who tend to be vulnerable to eating disorders have temperaments that tend to be anxious, perfectionistic, obsessive, very rule-bound and rigid, have difficulty with change and transitions. And these folks may undergo a stress, typically in adolescence, and that can include changing schools, a parental divorce, a traumatic event, puberty, and seeing their body change, and they increase their dysphoria, they become more anxious, and what they're looking for is a way to relieve that worsening mood and that increased anxiety. And the world around us tells us that go on a diet plan, go on a health plan, you'll feel better about yourself. And if someone's vulnerable to an eating disorder, their intended result is decreased dysphoria. But what happens over time is this neurobiological change that keeps the cycle going. And this is part of why it's so hard for individuals to recover from their eating disorder. So some of these psychological predisposing factors. So what, as you meet patients in your practice, in your day-to-day, those folks who struggle with perfectionism, sort of those OC traits, a lot of negative emotionality, the folks who are struggling with depression, anxiety, harm avoidant, and there are specific additional personality traits that may be associated with each type of eating disorder. And what I've noticed in my practice is the different types of behaviors that someone might use as part of their eating disorder often gives us a clue to their personality traits. So for example, those folks who persist largely with restrictive eating patterns often are the more anxious, avoidant, sort of over-controlled individuals. And what I've noticed is that individuals who engage more in the purging behaviors, whether it's laxative use, diuretics, or that self-induced vomiting, often fall into that under-controlled, sort of the more impulsive, compulsive type traits in terms of their personality. So sociocultural factors. So dieting is one of the greatest risk factors for developing an eating disorder. And I think this is highly problematic in that, in healthcare, we still tend to prescribe diets to folks. I'll talk a little bit more about dieting and the cycle of dieting and sort of what are the actual results of diets later. But I think it's important to be really mindful if we're talking to patients about weight loss or dieting to know that this is a risk factor for eating disorders. Like I already mentioned, transitions, whether it's in school or within families, is also a factor. Loss, violence, or abuse. Then we also have to look at our ideals of thinness that exist in our country and sort of in the Western world. Certainly traditional and modernizing roles, peer influences. There's certain sports where a particular body type is idealized and felt to be sort of optimal for performance, as well as media influences. And I think that media influence has only really grown over the years as social media and all these other options become more and more accessible to us as adults, but also to kiddos. Then there's also this problematic long-held view that eating disorders are disorders of choice or disorders of vanity, that largely sort of rooted in this idea that someone is striving for this cultural ideal of thinness, really devalues not only what we know about the neurobiological underpinnings of eating disorders, but the seriousness of the illness. It's really been a hindrance in terms of funding and research into eating disorders. So, like I mentioned previously, most of the time folks aren't going to show up asking for eating disorder treatment. They're going to show up with complaints either in the physical arena, often related to GI issues, or they're going to come talking about depression, anxiety, ADHD, struggling with self-harm. And so we really have to be looking out for the eating disorder that's behind the scenes that they're not telling us about. So mood disorders are going to be the most common psychiatric comorbidity, whether that's on the bipolar spectrum or the depressive spectrum, followed next by anxiety disorders. What we notice is that individuals who tend to engage in those purging behaviors seem to be the patients who are most predisposed to the non-suicidal self-injury, as well as the suicidality and suicide attempts, as well as the substance use disorders. So things we really want to think about, and I'm going to talk more about how starvation affects the brain, is that the eating disorder can mimic signs and symptoms of the comorbid diagnoses. The eating disorder can amplify the adverse consequences of the comorbid diagnosis. It's frequently a coping mechanism. So this is where I think about maintaining factors. So often depression and anxiety, OCD, substance use may be also a maintaining factor of the eating disorder because individuals are utilizing those behaviors to feel better in some way. They only have generally short-term benefit, but making sure that we're adequately treating those comorbidities so that we decrease that impact of the maintaining factors. So I talk a lot about the University of Minnesota semi-starvation study, even with my patients. So in my career previously, I worked at Acute, which is located at Denver Health. It treats folks who are generally less than 70% of their ideal body weight. And I've treated patients there as low as BMIs of 7.5. And so this study was incredibly relevant in that patient population. But it's also important to remember that eating disorders can exist in all bodies, in all shapes and sizes, and folks can be malnourished in any body, shape, or size. And so we need to be thinking about this effect of starvation on the brain in any of our patients who aren't getting an adequate nutritional intake. So this was done by Ansel Keys in 1945 in the context of World War II, where they were looking at the best ways to refeed individuals. So they were looking at wartime conditions, the concentration camps, and knew that if we didn't refeed folks properly, that we could kill them. And so wanted to learn more about not only the effect of starvation on the brain and body, but how to best refeed. And so while it's not specific to eating disorders, it's had very important implications for our field. So the men were healthy male volunteers. I think volunteers is a generous term because they were actually conscientious objectors to the war. So whether or not they were truly volunteers is hard to say. But what I do want to point out is that they were deemed healthy. So prior to the onset of participating in the study, they were assessed. They did not have any psychiatric conditions or medical conditions. And they went through this period of semi-starvation and refeeding, and it took up to 2 years for many of them to return to baseline. But what they saw in the study was really important for eating disorders because semi-starvation in and of itself can increase depression, anxiety, and a lot of other negative emotional states. It can make folks more rigid and more obsessive. These men also started to engage in self-harm when they previously hadn't. They started to become preoccupied with food, hoarding food, and engaging in binge eating, and experienced a lot of the physiologic changes that we see in individuals with eating disorders who are malnourished. So the reason why I bring this up is when you meet someone who is malnourished as a result of their eating disorder behaviors, some of the depressive, the anxiety, the obsessive symptoms that you might be seeing may actually be the result of starvation itself, as opposed to being a true comorbid diagnosis. So often when I'm meeting folks early on in treatment, I talk to them about this study and that, I may not at this point be able to diagnose them officially with major depressive disorder or OCD. It's something that we're going to have to weight restore them and get their nutrition back on track because some of these symptoms may actually go away just with food. If someone had a comorbid diagnosis of OCD or depression or anxiety prior to the onset of their eating disorder behaviors, you can be confident they likely still have that comorbidity. But what's really important to remember is that low body weight can actually affect sort of the eating disorder thinking and the cognitions, and that we really need to focus on normalizing weight and normalizing nutrition before we can expect their brain to follow along. And so as a psychiatrist, this is a really important consideration because my medications don't always work that well for individuals who aren't eating adequately or at very low body weights. So we think that serotonin is likely the neurotransmitter most affected by malnutrition because we depend on nutritional intake of proteins to get tryptophan, which is an essential amino acid. So if someone's nutritional intake is limited for any reason, then we can fully expect that the serotonin system will be impacted. And we think this explains poor responses we see to the serotonergic agents like SSRIs in malnourished patients. And what I talk to my patients about is that, we probably can't expect their medications to be fully effective for them until they're closer to 85 to 90% of what their body weight is supposed to be for them. So this can be really important to consider with folks when I'm starting medications if they're not eating adequately or they're at a very low body weight, is really setting good expectations with them about when I actually would expect the medication to become helpful for them. So another sort of hormone that can be important in eating disorders is vasopressin. So I think often this idea of self-induced vomiting is a very puzzling symptom for folks who don't struggle with an eating disorder. Why would someone do that? What is the reinforcing factor, or sort of in this case, the maintaining factor? So one of the things we think is vasopressin, when it's released to prevent the body from losing too much water, it actually creates this morphine-like high that calms the person as their body tries to adjust to prevent dehydration. And so in that sense, we can understand how self-induced vomiting could become a repeated response to create a temporary calm after someone eats or after someone binges. And so I often share this information with my patients who struggle with purging. They often feel very ashamed of that behavior. And I really try to help them understand why they might do what they do and how it helps them. Because part of our role when we're treating folks with eating disorders is how do we put the eating disorder out of a job? What is the function? What is it doing for this person? And what can we replace that with that's healthier and more adaptive and more effective? So eating disorders have lots and lots of medical complications. So these are the ones specific to malnutrition. So it really affects every organ system. And the reason why I wanted to bring this up is there have been some articles that have come out in the last couple of years about this idea of terminal anorexia nervosa, and this idea that, people will die from this illness. What I want to point out is that from a medical standpoint, there are no medical complications of eating disorders that are not treatable, and most of them are reversible with nutrition. And so there's no medical complication of an eating disorder that makes it terminal. The things that we think are not reversible at this point is osteoporosis, although we're very hopeful that with more access to PTH hormone analogs, that this may actually change and that there may be some reversibility for folks with their bone density. Looking at the medical complications of purging disorders, the one complication that previously has felt to not be sort of reversible is emmentine cardiomyopathy. So this was in the area when folks could access syrup of ipecac to induce vomiting. But those case reports are pre-beta blockers and pre-ACE and ARBs. And so we think that actually may be different now as well. But thankfully, syrup of ipecac is not widely available at this point. So prognostically, patients have a high mortality risk with eating disorders. Many of which are due to medical complications, but also suicide is really important. So good safety screenings with this patient population are really crucial. But what I want to point out is that there's often a belief that individuals with eating disorders can't get better, even if they've had the illness for a long time. We have data now following individuals out even after 22 years after their diagnosis, and some of them are still recovering. So I do think this is a message of hope for patients and families is this is a marathon, not a sprint. And even if it's 5 years in, 10 years in, there is still hope for that person. And we really want to continue to encourage them to move towards recovery. So as a psychiatrist, often capacity with eating disorders comes up. And when I worked out in Colorado, we actually were able to do involuntary treatment for eating disorders specifically. They're using grave disability, which is part of the law out there. But what we do know is that we often overestimate incapacity in patients with eating disorders. But when we look at capacity, it's much more complicated in this patient population. They're often very well educated, well spoken. They often can repeat back to us the risks and benefits of their illness and the treatment we proposed. But where they tend to struggle is how it applies to them, sort of the appreciation and the application of the consequences to their particular case. And that's where we really have to pay attention if we're asked to assess capacity of a patient with an eating disorder to refuse life-saving nutrition or other medical treatment. And what we really need to be mindful of is that, they may advocate for other forms of treatment, and we do really have to consider whether or not that treatment has any merit. And this slide, when it references gut feelings, so with patients with eating disorders, often because the illness is egosyntonic, it sort of hijacks their values and their sense of themselves as being separate from the illness. And the more we can get to know someone and identify what are their values, what's important to them, that may also give us a clue of whether or not they have capacity. So for example, I treated a patient back in Denver where when she admitted to our unit, she was very gung-ho about treatment, felt like she needed to weight restore. She was in a lot of physical pain given her low weight and some of the medical complications she was experiencing. But a few days into refeeding her body and tolerating treatment, all of a sudden she wanted to discharge. All of the goals that she had for herself on admission about going back to school and starting a family had gone out the window. And I had to assess her capacity to leave AMA. And it was really helpful for me in that moment to have some understanding of, I know that what this patient is saying right now, my gut feeling is that this is not congruent with what she actually wants for herself. And so that's, getting to know their values and who they are when they're not sick can be really useful, and also helping motivate them towards those values for recovery. So I'm going to talk a little bit about the different diagnoses. So we'll start with anorexia nervosa. So I'm not going to read the DSM-5 to y'all, but what I want to sort of highlight is that certain things about each diagnosis that I look for when I'm trying to assess what eating disorder a patient has. So important things with anorexia nervosa. You may have a patient who shows up who's at an extremely low weight, but they are denying that they're trying to lose weight. They're denying that they're afraid of weight gain. We still can diagnose them with anorexia nervosa if they demonstrate that persistent behavior that interferes with weight gain. So often, we'll prescribe a meal plan to them and they're going to follow it and they're not afraid, and then they keep not gaining weight or they're losing weight. And so it's important to watch out for that. There's also that persistent lack of recognition of the seriousness of the current low body weight. So even if they say to you, I'm not afraid of gaining weight, I'm not trying to be thin, if you're noticing that lack of recognition of the seriousness, that also will clue you into a diagnosis of anorexia. It has two subtypes, so restricting type and binge eating purging type. To determine the subtype, you're really going to focus on what are the behaviors in the last 3 months. So we definitely see crossover in individuals with anorexia from restricting type to binge eating purging type and back again. And so not taking the historical diagnosis as current fact and really diving into what are the current behaviors to make sure that you're capturing the most current accurate picture. So as a psychiatrist for folks with anorexia nervosa, I have no FDA-approved medications to offer them. Food is really going to be the primary medicine, sort of like we talked about with the University of Minnesota semi-starvation study, helping that individual normalize their nutrition and get to a healthier weight will really help us sort through what symptoms, mental health symptoms they're demonstrating are due to malnutrition and which ones are due to a comorbid psychiatric diagnosis. But like I also mentioned previously, if the onset of the comorbidity was clearly prior to the onset of anorexia, it may still be reasonable to treat before they are weight restored or at that 85 to 90%. We have more and more neuromodulation options that we can consider in patients with eating disorders. So one of the services we have at Eating Recovery Center where I work is we do have TMS. It helps with the symptoms of depression and OCD. Often we see these comorbidities as interfering with treatment, or the suicidality that can come with mood disorders, anxiety disorders, as well as just sort of the experience of weight restoration. So that's where we've seen ketamine be helpful. It also helps patients sort of gain some distance from their illness and sort of make new habits easier to form, old habits easier to break. And we've really seen a lot of safe use in our patients who are medically stable with eating disorders. ACT can also be effective in individuals with eating disorders for treatment-resistant depression, even if they are malnourished. Because again, if somebody's at such a low body weight where the antidepressants aren't going to work for them, I really need to start thinking about my other options. I've also seen several cases of catatonia in patients with severe eating disorder symptoms. it's been interesting as a psychiatrist to work with these patients with very extreme eating disorders. I've seen psychosis, full onset simply due to malnutrition. I've also seen mania that's resolved with nutrition alone. So really what I've learned is that the malnourished brain can present in a lot of different ways and with a lot of different conditions. So atypical anorexia falls under OSFED in the DSM. And, this is sort of a misnomer because this is actually seems to be the more typical form of the illness. About less than 6% of folks with eating disorders are actually underweight. And we've learned a lot more recently about atypical anorexia nervosa as it's been more clearly defined in the DSM. It's resulting in more research in that area and a better definition of the illness that we're looking at. I want to point out night eating syndrome as well. So this is recurrent episodes of night eating after awakening from sleep or excessive food consumption after the evening meal. You'll frequently see this co-occurring with binge eating disorder. So what distinguishes it from a parasomnia is folks will remember eating during the night and they'll remember what they ate. But often these are individuals who experience dysphoria that grows throughout the day and they feel like they can't fall asleep or stay asleep without eating. I've often ended up sending these individuals also for a sleep study just to make sure that there wasn't a parasomnia, because I've also seen some individuals who have told me they've eaten sort of baby formula powder during the night, and it was difficult to sort out whether it was night eating or sleep-related eating disorder. But what we've learned about medical complications of atypical anorexia is that the difference between their premorbid weight and their current weight is important for understanding the level of malnutrition and the level of risk from complications. And what we've seen is that the more significant weight loss, as well as the rate of weight loss, is really important in this. So folks who tend to lose a lot of weight or lose weight very, very quickly seem to be prone to more psychiatric and medical complications. But what we know right now is the medical complications seem to be of equal severity and of the same types as in the folks who have more typical anorexia. From a psychiatric standpoint, so the DSM often talks about, weight loss and what degree of weight loss someone would have to experience to meet criteria for atypical anorexia. And so there have been a lot of studies done to look at what is the degree of weight loss that potentially results in a clinically significant eating disorder. And they found that even just 5% weight loss from someone's natural body weight combined with cognitive concerns. So that's not a lot of weight. And so we really need to be paying attention in folks who have lost weight, even if it doesn't seem to be a very large amount, looking at those cognitions and sort of their behaviors to really look for atypical anorexia. But what we've seen that's really important is that often these folks have more severe psychological symptoms than those who are considered to have typical anorexia nervosa. They've also been more likely to have the experience of having their symptoms dismissed when their weight wasn't regarded as low when it really should have been for them as an individual. And it's really challenged our reliance on weight in the eating disorder field to determine illness severity. So turning to ARFID. So the big difference between ARFID and anorexia, the distinguishing factor that you're looking for is the presence or absence of body image distortion. So individuals with ARFID do not have the body image concerns that individuals with anorexia do, even though they may also be at a very low weight or be quite malnourished based on their needs. And ARFID can happen in adults. So it used to be thought of and sort of more defined in the DSM as a disorder of childhood. But we are seeing more and more adults present with ARFID and onset of ARFID in adulthood. So typically in the adult population, they seem to be more prone to the subtype fear of aversive consequences, and then second to that, lack of interest in eating. There's also a lot of crossover from ARFID into anorexia. So if you're treating a child or adolescent with anorexia, it is important to keep an eye on them because they may, or ARFID, they may end up later developing anorexia nervosa restricting type. And so talking about the 3 subtypes of ARFID, so they're listed in the DSM. So there's fear of aversive consequences, lack of interest in eating, and then this sensory-based avoidance. Sensory-based avoidance you're typically going to see in individuals on the autism spectrum. Like I mentioned previously, fear of aversive consequences seems to be the predominant presentation in adults, and it's usually related to GI concerns. They're afraid of vomiting, they're afraid of abdominal pain. Lack of interest in eating really can be seen in kids or adults. And these individuals really just don't find pleasure from food. It's more of a chore. And so what do you want to think about psychologically for each of these subtypes? So when you're assessing a patient with ARFID, they can have all 3 of these different subtypes. What you want to try and do is identify which one is the primary subtype, and that's where you'll start with your treatment. So if it's fear of aversive consequences, it's going to be psychoeducation, exposure, anxiety management. Lack of interest in eating, you're really going to focus on building a structure and a routine, as well as building habits around eating and finding ways to increase pleasure or enjoyment with food. And then for the folks who are struggling with sensory-based avoidance, looking at a sensory diet, desensitization, family intervention, and often with individuals with ARFID, occupational therapy has a lot of training that can be incredibly useful for these patients, and there are often OTs that have ARFID specialization. So I would really recommend looking at connecting your patient with an OT with ARFID specialization if possible. But really, individuals with ARFID need a multidisciplinary team. And there are different options for like CBT-AR manual, and there's also acceptance-based interoceptive exposure treatment. So what we often do on our units is have patients identify sort of their hierarchy of foods, similar like what we would do for an individual with OCD in terms of building their exposure hierarchy, and what are their safe foods, and sort of a red, yellow, green almost, and working through those exposures with them. So there are no FDA-approved medications for ARFID. So as a psychiatrist in the world of eating disorders, I live in a bit of a desert of guidance. Food is still going to be the primary medicine for these individuals, again, because they can be malnourished as a result of their ARFID. We do look for potential symptom resolution with weight restoration. But one of the things I sort of worked through on my own time when I was seeing a lot of adults with ARFID with that fear of aversive consequences is looking into the literature about the disorders of gut-brain interaction and coming up with sort of my own personal possible strategy to think about. Because what I want to do for these individuals with ARFID are make sure I'm addressing any comorbidities or anxiety around meals and timing to eat, as well as medications that might affect the GI tract. And so I really dove into the GI literature and learned about visceral hypersensitivity and, you know, what medications that the gastroenterologists use for that. And it really falls into, a lot of the medications that we use in mental health for depression and anxiety and these comorbidities. And so I'm often looking at the SSRIs, SNRIs, like duloxetine, venlafaxine, mirtazapine can be helpful in treating sort of this intersection between the GI tract and the comorbidities. Some of the atypical antipsychotics, for example, olanzapine, you know, has some off-label use for nausea and vomiting in individuals receiving chemotherapy. Maybe that would help with some of these patients. Anxiolytics like the benzodiazepines that can help with nausea. So moving on to bulimia. So sort of the big distinguishing factor between bulimia nervosa and an individual with anorexia nervosa, binge eating, purging subtype is you're looking at their weight. So individuals with bulimia nervosa will not be underweight in the same way that somebody with ANBP would be. But again, you're still looking at a time period for the last 3 months for their behaviors. And the purging behaviors can include self-induced vomiting, laxative diuretics, or other medications that can induce weight loss. So medications, we actually do have a medication that's FDA approved for bulimia. So that is fluoxetine at a dose of 60 milligrams a day. It doesn't mean that only fluoxetine can be helpful. I think that's probably just the only a drug company that pursued an FDA approval for bulimia, but thinking about fluoxetine if your patient has not tried that yet, since it does have FDA approval. So turning to binge eating disorder. So this is actually the most common eating disorder that you're likely to see in your patient population. And what you're looking for here to distinguish it from individuals with ANBP or bulimia nervosa is that their weight is not defined as low for their body, and they're not utilizing those recurrent inappropriate compensatory behaviors. So they engage in binge eating, but they are not inducing vomiting after, they're not using laxatives, they're not using diuretic. So like I mentioned, it's the most prevalent eating disorder, so it's the one you're most likely to see. And it's highly prevalent around the world. And one of the saddest things is that only about 38% of folks actually receive eating disorder treatment for their binge eating disorder. So a lot of the predisposing and precipitating factors are similar to all other eating disorders, sort of that negative affect, negative feelings about body and food. A history of dieting is a huge risk factor for binge eating disorder. And sort of the graphic on the right really shows you that cycle. If someone goes on a diet, it creates distress and deprivation for their body. Hunger increases. There's a physiologic drive to eat. They end up binging and then moving back through shame and hiding their behaviors and then re-engaging in the diet to regain control. And this, what we start to think now is that binge eating disorder, even though it's defined by the binge episodes, is really driven by restrictive eating. And one of the most important things that we can do for individuals who are struggling with binge eating disorder is to really focus on helping them maintain adequate nutrition throughout the day. So, like I mentioned, dieting is a huge risk factor for eating disorders. The healthcare profession continues to recommend dieting, but the success rate is actually incredibly poor for the results with dieting. Most folks regain 2/3 of the weight within 2 years. And for nearly everyone at 5 years, almost all the weight that was lost has been regained. And they're more likely to develop an eating disorder as a result. So we don't have any long-term data to support that diets are effective, and we're really increasing the risk that that individual will develop an eating disorder. And so, there's often greater body weight gain as a result of dieting. The weight rebounds from weight cycling is very difficult from the body. And it's really important to separate sort of weight from behavior. So binge eating disorder, we do have one FDA-approved medication. It's lisdexamfetamine. The brand name for that is Vyvanse, if folks are more familiar with that. But really, first and foremost, we want to help them stop the restrictive eating behaviors because that sort of restriction binge cycle will continue to push them towards binges if they don't. So when I think about medications for individuals struggling with binge eating disorders, so like I mentioned, we have the lisdexamfetamine that's FDA approved. What patients describe with lisdexamfetamine is it feels like it sort of silences all of the food noise in their brain. So what they describe is feeling like they're constantly thinking about what they've eaten, what they're going to eat in the future, what they ate yesterday, and what they have to do about it. And for the individuals where lisdexamfetamine is helpful, all of that becomes quiet, and they're actually able to focus on their work and move throughout their day without constantly thinking about food. You do have to be careful with lisdexamfetamine because it can exacerbate anxiety. It can cause sleep problems. Also, it's designed to wear off in the evening, and that's often when folks struggle more with their binge eating episodes. So really, again, if someone's taking lisdexamfetamine, it's important to make sure they're eating adequately throughout the day so that they don't also create that physiologic drive to binge in the evening. Most folks who end up with diagnoses of binge eating disorder have an experience of trauma in their life. Some of the data suggests above even 95%. So thinking about medications that can be helpful with trauma symptoms. Naltrexone is something that we've tried for off-label symptom management. Some folks find it beneficial for decreasing binge urges. And then we just really want to avoid any medications that might make the binge eating worse, which can be the antipsychotics, mood stabilizers, or any kind of antihistamines. There's a lot of interest now in sort of the GLP-1 receptor agonist and the intersection with eating disorders, and in particular, would they be helpful for individuals with binge eating disorder? So we're still learning the pros and cons of these medications. They act in a lot of ways in the body, in a lot of different organ systems. But we've already identified a lot of potential harm in the area of eating disorders. So not only does it refuel this cultural and medical myth that weight is a choice and size is a disorder, we definitely see it exacerbating historical eating disorders and resulting in new onset eating disorders. And these medications are rife for potential misuse for weight loss for those who don't meet criteria for them. And we're seeing more and more patients show up to our treatment centers on these medications, including individuals who are already extremely underweight. We recently treated a patient here in Chicago who was sourcing these medications from 3 different sort of clinics, spending a tremendous amount of money each month, but was essentially taking 3 times the dose that would ever be prescribed, even if it was being appropriately prescribed. So we know individuals with eating disorders already have vulnerable neurocircuitry, dysregulated appetitive behaviors, and disruptive reward mechanisms. And we do see these medications exacerbating restrictive eating, causing malnutrition. And as we've kind of already learned in this presentation, malnutrition is only going to worsen their disordered eating thoughts, as well as anxiety and depression. We don't have any long-term data on adolescents. And so what we've done in our facility so far with these medications is, if folks are on them when they arrive, unless they are here to be treated for anorexia nervosa, we are allowing them to continue the medication as long as they're able to engage appropriately in treatment and work on adequate nutritional intake. We know that folks have choices. We want to support their bodily autonomy and also want to do our best to still treat the eating disorder. Because unfortunately, there's no data yet to say that these medications will treat eating disorders. And in fact, a lot of the data we're seeing is that it actually will cause eating disorders or exacerbate them. So binge eating disorder can be challenging to identify and treat, again, because folks tend to feel a lot of shame about binge eating. And so they aren't likely to come and tell us that that's what they're struggling with. They're more likely to come and report a variety of physical symptoms, depression, and anxiety. There's also a lot of stigma around binge eating disorder and certain body shapes and sizes in our culture. A lot of times binge eating disorder gets described more as emotional eating, secondary to a mood disorder as well, instead of being recognized as an eating disorder. Often folks with binge eating disorder don't recognize that their symptoms are the result of a clinically significant and known eating disorder that requires treatment. And folks are still more often funneled towards weight loss options as opposed to eating disorder treatment. I think there is also a tendency amongst medical professionals to focus on treating the medical comorbidities with an emphasis on weight loss as opposed to looking at the eating disorder first. And then just, patients often are not going to be forthcoming with us. It's really about building rapport and creating a space where they feel comfortable talking to us about their eating disorder symptoms. But there are tremendous impact from weight stigma and weight bias. So we know that this is a global, pervasive issue that affects individuals in multiple domains, including academics, their employment, and in healthcare. And what we've actually learned is that when an individual goes to a doctor's office and they are prescribed a diet or they're told to lose weight, that actually is more likely to result in binge eating. And so often this advice or recommendations that they're given with the intention of sort of supporting their health actually backfires and makes the binge eating worse. But these are also individuals who have often been invalidated in their experience of their illness from providers, insurance companies, and society as a whole. So often we see in the eating disorder world that insurance companies will deny these patients appropriate levels of care and or appropriate duration of treatment because they perceive their BMI is normal, or that even the insurance company thinks that they need to lose weight. But we do see that individuals with binge eating disorder can benefit from residential care and partial hospital care to help, really start to abstain from the behaviors and develop that more adequate nutrition pattern throughout the day. They're often delayed in getting their diagnosis because of misattribution of symptoms or just the discomfort in reporting to healthcare providers. In Colorado, when I lived there, they actually passed a law that was going to prevent insurance companies from denying eating disorder treatment based on BMI alone. And I think that was a move in the right direction to increase access to care. Often these patients feel like they're not sick enough, that if they haven't been able to achieve sort of the thin ideal and that underweight body, that they have failed at their illness or they're not good enough at having their eating disorder. And so often they can be more reluctant to seek treatment or think about normalizing their nutrition because they feel like they haven't done it right yet and that they don't deserve treatment. And so, like I mentioned, weight bias has a lot of negative impacts, including potential for increased weight gain because it does seem to worsen binge eating or overeating as opposed to decrease it. Self-esteem, social isolation. A lot of times these patients will avoid coming to see us because, what I've heard from some of my patients that I've treated with binge eating disorder is that they go into the doctor, they have a sore throat, and instead of just getting their strep test, they get a lecture about their body shape and size. And so then they just stop coming to see us. And that's really unfortunate because, we miss opportunities to provide them the support that they need. And, what they've seen is that if we, as their providers, demonstrate weight bias, less likely to be satisfied with their visits, lower quality of care. What they've seen in some studies, for example, is that providers actually spend less time with patients and are less likely to provide education about their health concerns and their medical conditions and their treatment options. And so another thing that we always want to think about is our environment of care. Are we creating a welcoming space for folks of all shapes and sizes? And it really is looking at our furniture and our gowns and our towels because we really want to be welcoming, and folks are going to be much more likely to talk to us about what they're struggling with if they feel comfortable in our spaces. So this has been a real important wake-up call for the field of eating disorders, is that, we never want to make diagnostic or behavioral assumptions based on someone's size or weight. We want to talk to everyone about disordered eating. And for all patients, regardless of their eating disorder diagnosis, recovery without nutritional stabilization really is impossible. Folks need to normalize their eating patterns and get to a healthy weight for their own body in order for their brain to really psychologically recover. We can't expect their brain to normalize the relationship with food and weight if they do not get to a healthy weight and maintain good nutrition. So when do you want to think about referring patients to an eating disorder specific program? So you're really looking at medical instability. Is there the presence of suicidality concurrent with the eating disorder? Where are they weight-wise? And often that is also important to look at where are they relative to what we would expect their body weight to be for their body or within their weight history. What is their motivation to recover? Folks may be able to pursue eating disorder recovery in the outpatient setting, but really if they don't have good insights, if they're not very motivated, it's going to be much more difficult for them to do that with that more limited support. Looking at co-occurring disorders that might interfere with their progress towards recovery and might be those maintaining factors for the illness that may need a higher level of care treatment as well. Compulsive exercise. So this is a real challenge in our field. We don't have a lot of great treatment options that are evidence-based at this point for compulsive movement, but it really is a behavior that can substantially interfere with weight restoration and medical stabilization. So for example, I treated an individual out in Denver who had anorexia nervosa restricting type. He also had very severe OCD. And he needed pretty substantial weight restoration, about 40 or 50 pounds, but he paced so much within his hospital room that he was receiving 6,800 calories a day by tube feed and still not gaining weight. And we really had to get really creative about all the ways to try and help him manage his compulsive movement so that we could get him on the path to weight restoration. But also all of that nutrition was taking an incredible toll on his liver and kidneys. And so he was actually starting to sustain medical complications from all of the nutrition that we were having to give him. Purging behaviors can be very difficult for individuals to stop in the outpatient setting. So there's a thing called pseudo-barter syndrome. So what happens is when someone engages in purging behaviors over time, the body releases more aldosterone to help maintain blood pressure and sort of maintain homeostasis. If someone stops engaging in purging behaviors abruptly, that hyperaldosterone state persists for several more weeks. And what they're going to do is retain a profound amount of water very quickly. This is why often patients are very reluctant to come into emergency rooms to get care, is when they're given fluids, they tend to retain all of that fluid if they're not purging. And the level of edema can be profound and very, very distressing for patients. And so it's often really important to get them into eating disorder care so that we can medically manage that, but also to support them with any distress that comes with that experience. And then just what does their support system look like? Because this is often a group effort. Individuals can't recover from eating disorders alone. And so if their supports are limited, it can be really important in considering a referral to a more eating disorder specific program. So there are level of care and treatment guidelines that y'all can always look at through the Red C or the APA. The other easy option that you have is if you have a patient who's struggling with an eating disorder, is call an eating disorder program. It could be Eating Recovery Center, it could be Montanito, Alsana, any of the programs. They'll do an assessment with your patient and they will make a level of care recommendation. So you don't need to figure that out on your own. There are people within all of these eating disorder treatment programs around the country who can help with that. So there are a variety of levels of care for eating disorders. So we have medical stabilization, that's all the way on the right. So that's folks who are typically less than 70% of their ideal body weight, or folks who are experiencing medical complications of their eating disorder. And then within the behavioral health spectrum, we have all the way from outpatient to inpatient eating disorder treatment and residential, which is 24-hour care. And really the level of care that's appropriate for your patient is going to depend on what kind of medical stability do they need, what are their comorbidities, and what is their willingness to engage in treatment. And so some of the messages I want to send is just, this is a marathon, not a sprint. So the average treatment course is about 5 years. Setbacks and relapses are to be expected. Patient ambivalence is the name of the game. They often are very conflicted about the idea of giving up their eating disorder. It's important to be really consistent in their messaging. They need to hear the same thing from everyone on their team. They're very sensitive to differences in messages about whether or not they need to gain weight or maintain good nutrition. Right now there is no such thing as terminal anorexia nervosa, and we always have patients who can get better even many, many decades after the onset of their illness. So we want to be the bearer of hope. And so last few things I want to highlight is just weight is not the only clinical marker of an eating disorder. We really need to pay attention to the potential impact of malnutrition on their psychiatric presentation. Weight restoration and nutritional rehabilitation is non-negotiable. Therapy needs to be a non-negotiable for our patients. We don't have very many medication options to treat the eating disorder directly, but really using our resources to target the comorbidities that might be maintaining factors of the illness is always going to be a good idea. And unfortunately, at this point, all eating disorder care is still not equivalent. We really want to keep focusing on good outcomes and size-inclusive care. And I put up some recommended readings, so both from a medical and a psychiatric standpoint of books to consider, as well as other medical guidelines. So I will leave that up, but just I'm available for any questions if anybody has any.
Sure, go ahead, Dr. Spencer.
Okay,
Number one, you talked about TMS for anorexia. Was that directed at any particular part of the brain? I mean, transcranial magnetic stimulation, right?
Yeah. So
where would it be targeted?
Yeah, so the TMS itself isn't going to be specific for the anorexia, but it's really going to target the comorbidities that may be the maintaining factors of the illness, whether it's the TMS for major depressive disorder or for OCD. By treating those comorbidities, we will often see benefits for the eating disorder as well.
Okay. And the other is, I'm always been interested in satiety and the arcuate nucleus and the leptin-ghrelin balance, the hunger hormone, those type of things. Are those ever measured or looked at in these people?
Occasionally. So, there is this idea of where I often have seen it used as the idea of constitutional thinness. So often our patients with eating disorders will come to us and say, I'm just constitutionally thin. My family is thin. I am meant to be 80% or 75% of what my body weight should be. And so we will often check once we've done some weight restoration with those individuals, we will often check a leptin level just to see, if they're back in the normal range, then maybe their target weight does need to be lower than what we would expect for their body height and, relative to their family history. So that's where I've seen it most commonly used, not necessarily otherwise in clinical practice right now.
Thank you.
There's some new exciting research coming out about donepezil or Aricept. So like I mentioned, compulsive movement is a really challenging symptom to treat. And so there's been a psychiatrist up in Canada, Leora Pinhas, who's been trying donepezil in patients for compulsive movement because we know that there's some level of acetylcholine dysfunction in individuals with anorexia. And so when things between acetylcholine and dopamine get out of whack in the striatum, it seems to make individuals more likely to develop these compulsive repetitive behaviors that are no longer goal-oriented. So that's been some exciting new research is donepezil at doses of 0.51 milligram. So we're hoping for more options to treat these individuals because it's a very challenging patient population and these symptoms cause a tremendous amount of suffering.
Yeah. There was also just the whole concept of, I always think about, there's a couple things. One is reward in eating.
Mm-hmm.
The point of eating, you want to feel good, after you eat. And that's very much dopamine driven, and that has an anatomy to it. Is that ever investigated, or is there a way of looking at that to see if that's what's awry?
So they do think for some folks, dopamine dysfunction is part of the picture, particularly individuals with binge eating disorder. And what they've seen when they've looked at dopamine for those individuals is that there tend to be the dopamine spikes prior to eating. And so they get sort of a lot of quick reward with the idea of eating. And when they start to eat and then that diminishes, individuals with anorexia, they seem to have underfiring of dopamine relative to nutritional intake. So they don't get the same reward from consuming nutrition as other folks do. There's also a lot of interesting research now into serotonin and anorexia nervosa. So what they've seen is in individuals with active anorexia nervosa, but even in recovery states, is that higher levels of serotonin metabolites in their CSF. And so one of the things they've postulated is maybe because starvation can bring down serotonin levels in the brain by reducing tryptophan and production is, do these individuals almost have too much serotonin? And so starvation is sort of a mechanism for them to bring that down because it's uncomfortable. So there's a lot of interesting research happening to try and understand the neurochemical underpinnings. Hasn't really translated into more treatment options yet for us, but.
And on a very practical level, I know you alluded several times about don't tell people to lose weight, basically is what you said. Mm-hmm. But obesity is a problem. Mm-hmm. And, from my perspective, you're seeing people with hypertension, stroke, heart disease, diabetes. And weight is an impediment. I mean, they aren't going to get better unless they do lose weight.
Yeah, it's a real challenge because dieting is a risk factor for eating disorders. And we don't have a lot of data to say that our recommendations for them to diet per se are going to have the outcome that we're looking for. The data just doesn't support dieting as an intervention. But yeah, it is really complicated because I've treated many folks with binge eating disorder with BMIs as high as 90. And the reality is that, for them to have a normal lifespan, they are going to have to sort of change their weight to some degree because of the stress that it's putting on their heart and their lungs and other organ systems at that point. And so, our approach with patients where we've identified an eating disorder is really like, let's work on your eating disorder. Because if you do choose to pursue a diet or you do choose to pursue weight loss options, if your eating disorder is not well controlled and you're not managing and you're not paying attention to it, you are less likely to be successful with any of those things. And so that's really the approach that we've tried to take with folks.
Understood.
Any other questions for me? Thank you so much for having me.
Thank you for presenting for us. That was a great topic. We appreciate your time.
Thank you.
All right, have a good day, y'all.
You as well. Thank you.